What's up, guys? Welcome back to From the Ground Up. Today's episode is probably going to get a little spicy, but it's literally only because I want you getting better outcomes for your patients, guys. I sometimes just got to get passionate, got to get a little spicy, okay? So if you are still kind of sorting your patients into the two buckets, that is pelvic floor weakness and pelvic floor tension, my guess is you are probably getting a little bit stuck with your patients. Maybe they're not getting all the way to 100%. Maybe they're getting better, but it's only with lower level activities. Maybe they're getting better, but the results aren't sticking. Maybe they're getting better, but it's only because they have all these management tools and techniques to manage their symptoms between appointments. And truthfully, I hear so many pelvic floor therapists reducing pelvic floor dysfunction as a whole to either weakness or tension. These are literally the two buckets that we are taught that the pelvic floor can fall into when it's being dysfunctional. These are the two buckets I was taught, right? I was taught kind of this framework of assess the pelvic floor muscles, hear the symptoms from the patient, and it's likely that their pelvic floor is either too tight or it's too weak, right? And that's what we're taught. But I want to challenge it because I believe that the pelvic floor is not just tight or weak. Those are symptoms, those are descriptions of how the pelvic floor is functioning. They are not the why, right? They are not why the pelvic floor is dysfunctional. The pelvic floor is typically a victim. So the tension or the weakness are the symptoms of something. They are not the reason that tightness and weakness is happening, right? They're the descriptor of the muscles themselves. So today I want to give you a simple way to kind of stop defaulting to throwing your patient's pelvic floor dysfunction into one of these two buckets so you can actually help your patients and your clients overcome their pelvic floor issues and be able to push themselves harder in the gym or in life, or not have to be stuck with all these management techniques and tools for literally the rest of time, right? And commonly, the common model, this weakness versus tension, kind of leads us to these two buckets of a weak pelvic floor is usually described as a lengthened pelvic floor. It is lax. It is weakened. And we're taught that the diagnosis or the symptoms that falls into this weakness bucket is things like stress incontinence, pelvic organ prolapse, things like that just kind of fall into this bucket of the pelvic floor is so weak. And that's why it can't hold pee in. And that's why it can't hold the organs up because it's so weak and lengthened, right? And then there's the tension or the tightness bucket. And the patients that we're taught to put in this bucket, this tight, tense, shortened pelvic floor are patients with urinary urgency, frequency, constipation, pelvic pain, dyspareunia. Those are kind of the patients that we kind of put in this tightness and tension bucket. And it's based on the symptoms that they tell us and our internal findings. We're taught to kind of okay, are they dealing with urgency, frequency? Are they dealing with stress incontinence? And then test the muscles and kind of confirm that the pelvic floor is either weak or tight, right? And yes, we can find these patterns, right? We can find a tight pelvic floor might also be someone that is dealing with urinary urgency, right? Or a pelvic floor might test weak, and that person might also deal with stress incontinence, right? So we can find these patterns, and I want to push on tightness or weakness is still not the important diagnosis, and it's certainly not the full picture. Right? I found in plenty of my patients that on a pelvic floor strength test, right, they might test weak, but they might get a 2 out of 5, but I'm feeling trigger points and they have pain, right? So it's it also just doesn't always match up into these two perfectly separated buckets that we're taught to put them in, right? And we're taught people with a weak pelvic floor, so our leakers or our prolapsers need Kegels, They need hip strengthening, clamshells, bridges, you name it. They need TA activation and strengthening. The list goes on and on and on of what we're taught that these people in this weakness bucket need. Okay. Essentially, they need strength, is what they kind of boil that bucket down to. And then we're taught that our people who fall into the tight or tense pelvic floor bucket need breathing. They need to relax. They need to lengthen the pelvic floor. They need to stretch. They need more manual releases, right? And those are kind of the common treatment methods, treatment modalities, whatever you want to call it, that fall into each of those two buckets. And I'm sure that you were taught these things, and maybe you even kind of think in this way. And hopefully by the end of this episode, you have some other tools and a new framework to be thinking through to not reduce our patients to just tight versus weak. Because when we treat tight or weak as the problem or the meaningful diagnosis, right, we stop asking why the pelvic floor is presenting that way. And we certainly don't get to the bottom of what's actually causing that tension or that weakness because we're so fixated on the pelvic floor is tight, so let's stretch and relax, or the pelvic floor is weak, so let's Kegel and clamshell and TA to high heaven, right? And tight and weak also aren't opposites. Like, you could have a tense pelvic floor that is weak, like you could have both at the same time. So it's like annoying to me that those are the two bucket options that we're given. And tight and weak are both kind of like symptoms or presentations. They're compensations for something else, right? And that narrowed thinking is what is keeping you and your patients, frankly, stuck, right? Stuck at 50% improvement, 80% improvement, stuck utilizing their stretches for the rest of time to manage their tension, stuck having to squeeze and lift the pelvic floor and engage the core to push themselves harder in the gym, right? And that's where we're keeping our patients stuck with these compensatory strategies by reducing their pelvic floor to a tight bucket or a weak bucket, okay? So I also want to touch on in this day and age of pelvic health care, there's this movement, and there's been movements, the pendulum swings one way and then it swings back the other, right? And so we're kind of in this movement right now of like, kill the Kegels, like stop doing Kegels. Kegels are dumb, and like, yes to all of the above. And most people are saying don't do Kegels because your pelvic floor might be too tight. And if your pelvic floor is tight and you're adding Kegels, you're adding more tension, right? That's why people are saying don't do Kegels. So I love the don't do Kegels part, but I don't love the part that says don't do Kegels because you probably have a tight pelvic floor, not a weak pelvic floor, right? I think we shouldn't be doing Kegels and giving Kegels to our patients because Kegels don't actually train the pelvic floor to do its job automatically, like it's supposed to, during real life. When they're walking, when they're running, when they're lifting their kid, when they're lifting the barbell, when they're coughing, sneezing, jumping, cutting, landing, chasing the dog, like whatever it is, doing Kegels does not train that functionally. No matter how you spin it. If you add a Kegel to a deadlift, still doesn't matter because why are they having to do a Kegel? Why is their pelvic floor not doing its job automatically, right? It comes back down to why. Why? Why are they tense? Why are they presenting weak? Okay. Kegels do not train the pelvic floor to do its job automatically. And so that argument of don't do Kegels because your pelvic floor is probably tight doesn't matter. It no longer holds up because we are not putting our patients in a tight versus a weak bucket anymore. And I'm going to explain what you can do and what you should do instead, but just hear me when I say that is not helping anyone. That is not helping your patient, and that is not helping you get to the root cause of your patient's symptoms, okay? And I'll just say Kegels are not evil. They're not the devil. They are just not the lever to pull if we want to find the root cause and fix it. Okay. I don't care if you have a tight pelvic floor or a weak pelvic floor or a mixed pelvic floor. It does not matter to me. We don't need to be doing Kegels because it's not going to fix the problem at hand. Okay. So just a little challenge for you if you are someone who has kind of removed the Kegels, but you're kind of still stuck in that tight versus weak lens, you're still limiting your patient. You're still kind of creating those labels. And I'm not saying this to put you down or call you out. Like, y'all, I used to treat this way. Like, I thought this because I was taught this, right? And I just am so passionate because now that I have learned a different way to assess and treat the pelvic floor, like, I want you all to know it because it works and it's so much better and patients like it more. And they don't feel like they have to just like contract or relax their pelvic floor for the rest of time based on them being tight or weak. Like, it's just so freeing when we can help our patients restore the automatic functionality of the pelvic floor muscles. And this is what I teach. This is my entire framework. So, a couple clinical examples to run through this. Take stress incontinence, right? Historically, stress incontinence has fallen into the weakness bucket. Oh, you leak pee because your pelvic floor is not strong enough to keep it in. Okay. But what if our patient leaks on, let's say, impact when she's jumping or running, right? But you do the internal strength test of the pelvic floor and it's a 5 out of 5 or, 4+ out of 5, whatever, when she squeezes it. Are we still going to call that weakness since she's a stress incontinence patient and she belongs in the pelvic floor weakness bucket? Or maybe we're progressive in our thinking and we're going to say, well, she's a 5 out of 5, so it can't be weakness. So she must be leaking because of the tension. There must be tension in the pelvic floor. And that's kind of where the pendulum has swung, right? It's like, oh, guess what? We now know that most pelvic floors aren't just weak. And like so many of them are tight, right? So now a lot of our patients fall in the tight bucket, the tension bucket, right? So is it tension? Since the manual muscle test checked out 5 out of 5, right? Or what if it's neither? What if it's neither weakness nor tension as the main root driver, the main root cause, right? Could it be that the stress incontinence for her is a pressure and force absorption issue? Could it be that her pelvic floor cannot manage the forces coming from, the ground reaction forces as she's running, jumping, landing on impact? Could it be that her pelvic floor is not handling the forces that are coming up from the ground well? Could it be that she has excessive pressure coming downward from above it, from, the rib cage, from the abdominal region, the thorax, all of that area? Could it be that she has so much pressure coming down and her pelvic floor is unable to adequately manage it under impact because it's too much and the pelvic floor can't do its job, right? So neither of those, it doesn't matter really at the end of the day if it's a tense pelvic floor bucket or a weak pelvic floor bucket. What matters is, why is the pelvic floor not absorbing and transferring those forces like it should be? Or why is the pelvic floor not capable of managing the pressure from above like it should be? Why? And to do that, spoiler alert, we're going to have to get out of the pelvis, okay? Here's another example. Pelvic pain patient, okay? Let's say this patient has dyspareunia, okay? Historically, we put this patient in the tension bucket. We say, you are a pain patient, you go in the muscle tension bucket, the pelvic floor tension bucket. That is what we're taught. If our patient is guarded and has pelvic floor tension because of, maybe she has fear of penetration, maybe she has a history of trauma, maybe she has just a history of dyspareunia, and so it's kind of reinforced this process and this idea of penetration is painful. Maybe she has pain and dyspareunia because she has poor pressure strategy and she just has so much constant pressure coming down from above that the pelvic floor is like squeezing to fight it and to manage it constantly and consistently. And so that's produced this muscle tension, which is tender and painful, right? Does stretching fix that tension then? If she's in the tension bucket because she has pelvic pain, and we're taught that patients in the tension bucket need to relax, breathe, stretch, does relaxing, breathing, and stretching fix the tension? No, because it doesn't fix why the tension's there. What is the root cause of the tension, you guys? Let's figure that out and stop giving people these Band-Aids to manage the tension. And we need to actually be addressing the drivers of the tension or the weakness instead of just giving them these temporary relief tools. And to be clear, I'm not opposed to giving patients things that bring temporary relief. Y'all, that is not a bad thing. There are so many great tools, great stretches, great breathing exercises, great manual techniques, wands, like all the things. Okay. I use these things with my patients, but they are tools. I am advocating that we stop giving our patients these types of interventions that are giving them temporary relief and calling it good enough treatment done because you've equipped them with this breathing exercise, this stretch, and taught them how to use the wand. Great. Now you're equipped to go manage your pain for the rest of time. Like, why don't we just fix the pain? You know, like it's just, I just want to scream sometimes because I'm like, we have to stop reducing our patients to pelvic floor tension or pelvic floor weakness. Like it's not going to help them in the long term. It's just setting them up to have to manage the symptom of weakness or tension for the rest of time. All right. And it all comes back to this idea of the pelvic floor being the victim, right? Like the pelvic floor being weak or tight and tense is a victim to something. And it is our job as their treating provider to figure out what the heck it is. The pelvic floor, right? It responds to demands. It responds to loads. It responds to pressure. It responds to our thoughts. It responds to our nervous system. It responds to our gut. It's responsive to so many parts of our lives and our bodies, right? It's going to brace. It's going to grip. It's going to not be online. Like it's going to go offline depending on what the system is asking it to do and what the system itself is doing or not doing, right? So the system being the biomechanical system, the nervous system, the whole entire human organism that is before our very eyes, right? There's a whole system and then there's systems within systems. And the pelvic floor just happens to be the central hub of all the systems. And that's why we see so much breakdown and dysfunction and symptoms at the pelvis and the pelvic floor because it has so many jobs related to biomechanics and nervous system and gut and all of the things. Like it does a lot of things and it's the literal center of our body. So it's going to be impacted by multiple systems in our body. Okay. So the pelvic floor is going to do, I'm going to say that again. The pelvic floor is going to do what the system is asking it to do. And it's going to respond to what the system itself is either doing or not doing. So if our biomechanical system's not doing its job, guess who has to step up to the plate? The pelvic floor. And then it fails, okay? Because it can't do the job of the whole body to transmit load and force and manage pressure. It can't do that. And that's what I want you guys to be thinking through is like, why is the pelvic floor tight? Why is the pelvic floor weak? Why is my patient's pelvic floor symptomatic? And let's figure that out. If we really want to determine what is causing it, if we really want to be able to say, okay, maybe you do have pelvic floor tension, maybe you do have a weak pelvic floor. Like, I don't frankly care. I'm like, why? If we really want to do that, if we really want to determine the cause of the tension or the weakness, we have got to zoom out. We have got to zoom out of the pelvis and the pelvic floor. We have got to look at the rib cage and learn how to assess it. We have got to learn how biomechanics of the pelvic bones itself impacts the pelvic floor muscles' ability to do their job. And this is simple length tension relationship that we all learn in PT school. It's like, the length and tension of a muscle or a group of muscles, it's going to be impacted based on that length tension relationship and its ability to turn on when it needs to turn on. We know that about any muscle in the body. Why is it different at the pelvic floor? Newsflash, it's not. And because the pelvic floor attaches to the pelvic bones, the innominate bones and everything, when those bones move, it is going to alter the length and tension of the pelvic floor muscles, which is going to alter its ability to function and to do its job. So we have to understand pelvis biomechanics because the bony position of the pelvis impacts the pelvic floor muscles, okay? We have to assess and understand the foot and ankle and its implications on the kinetic chain and how that impacts the automatic function of the pelvic floor muscles. We have to understand the nervous system and the limbic system and how nervous system and emotions impact the pelvic floor's ability to do its job, right? We have to understand the gut and how gut dysfunction impacts the pelvic floor's ability to do its job. We have to understand how our patients' beliefs and their daily activities and habits and postures and loads and, how they train and everything like that. All of that stuff, how is that impacting the pelvic floor's ability to do its job? We have to zoom out and look at all this stuff if we really want to determine what is causing weakness or tension at the pelvic floor. Like if the rib cage is a mess and it's locked down and pushing pressure down, and if their foot is a brick and not moving, why are we blaming the pelvic floor? Why are we saying, oh, you just, must have pelvic floor tension because you have hip and pelvic floor pain? Like you have tension, let's stretch and breathe and relax. Like, no, like fix the foot. And now the kinetic chain can move and now the pelvic floor can achieve its length and be able to do its job. Okay. So it's just, we have to be zooming out, y'all. So I told you I wanted to give you what you can actually be doing. I've talked a lot about what we don't do. Let's stop putting patients in the bucket of either tension or weakness and reducing them to those things and saying tension people get these types of exercises and weakness people get these types of exercises. Like full stop. Let's go ahead and can we all agree to stop doing that today? So I want to give you something that you can be doing. And I have this little simple framework that I teach in my course. And this is how I approach treating the pelvic floor, right? And it's, you can remember it thinking of the word root, okay? Like root cause. And it's an acronym. So ROOT. The R in root simply is just reminding you find the root cause. Okay. What is the main driver of this tension or weakness? What is the main driver outside of the pelvis, probably, potentially, that is causing the pelvic floor to not be able to do its job? So R stands for, don't forget, we want you to find the root cause. Then the first O is observe. So this is kind of going to be your step-by-step plan, the O, and then the T. So the first O, observe, this is reminding you to observe. It's just really, it's this simple, you guys. Like, what am I seeing in my objective testing, in their functional movements? What is the patient telling me about her symptoms, her story, her goals? Like, as I observe this human being in front of me, all aspects of him or her, right? I am taking it all in and I am starting to form a working hypothesis in my brain about what I want, what I think is going on, what I think could be the main root causes, right? I'm observing all of these things in her. Then the second O is optimize. So once we've kind of observed our patient, functional movements, objective testing, subjective evaluation, all of those things, once we've observed all of that and we kind of have this working hypothesis of what's probably the main driver or a few of the main drivers, then we go to the second O, which is optimize. We restore and optimize that part of the system that you identified as limited or that you identified as likely a main driver so that the pelvic floor can be optimized to work automatically, right? So the first O was observe. We observe and kind of make our hypothesis of what the main driver probably is. Second O is optimize. We are optimizing the pelvic floor and its ability to work automatically by optimizing the system, okay? Based on what you found in the observe, okay? Based on what did you identify as you observed your patient as the likely main driver. This could be biomechanical. This could be nervous system. This could be gut. It could be anything, but you have to observe it and then tackle it so we can optimize the system, okay? Then the T of root is transform. And I love this one because I don't know about you, but I'm in the business of changing lives. I want to transform lives. And so what I want us doing is observing and then optimizing the system and then transforming the way that we approach their rehab so that way they can have a changed life. And this really looks like, how are we going to work to transform their life by increasing their system capacity and their resilience through functional movement, loading? Like, this is kind of us going beyond, okay, I observed this thing, I've optimized the system, and so now you're done. No, this is let's take it one step further and actually ensure that we have rebuilt their capacity and built some resilience into their body, their system, their pelvic floor, all of the above. This is us challenging through rehab and through lifestyle and habits. This is us challenging just kind of the norms of, yeah, let's give some clamshells and some bridges. And, instead it's like, how can we further load and challenge this patient and her body and her pelvic floor? So that's the root. It is root. The R stands for remember to find the root cause. And then we have observe, optimize, and transform. So tomorrow in the clinic, what you can kind of take away from all this is if you have a patient, right, start with the goal task. Like, are they wanting to not leak when they cough? Or, do they not want hip pain when they squat? Do they want to not leak when they jump and run? Like, whatever it is, like, what is the goal task? Okay. Then you're going to watch and observe the movements that pertain to that desired outcome. So you're going to do some good, high quality objective testing and things like that and functional movement assessment. You're going to assess their foot, ankle, pelvis, rib cage, find some limitations within those functional assessments, right? Because you're watching their movements, you're watching some functional assessments, and you're probably picking up on, it doesn't look like when she squats, like her heel's coming up. So maybe her ankle is stiff. Okay, I'm going to dive a little deeper and test there, right? So you're assessing outside of the pelvis, the foot, ankle, the rib cage, looking at pelvis biomechanics. Sure, assess the pelvic floor muscles as well, of course. Like, let's see what's going on in there. And then you're going to decide what is the likely main driver based on what I'm seeing and what this patient is telling me, right? So with what you're hearing from your patient and what you're seeing and assessing with everything, what is the likely main driver? And you might have like 1, 2, or maybe even 3 floating around your head, but what's the likely main driver based on what I'm seeing and what this patient is telling me? Then you build the plan around that main driver, not around she has pelvic floor tension or pelvic floor weakness because of these symptoms, right? Or even based on my internal exam. Like, I want you building your plan around what you identified as the likely main 1 to 2 drivers of the tension or of the weakness. Okay. And this cycle will repeat itself, right? You often tackle kind of 1, maybe 2 main drivers at a time through some exercises, some manual, maybe a few visits, and then you circle around to the next one because a lot of patients have, multiple things going on. Our patients sometimes are like onions, y'all. Like, we go layer by layer by layer and peel it off until there's nothing left to peel off. And now they're great. They're resilient now, right? So tight versus weak when it comes to the pelvic floor, right? Tight versus weak, they are just not meaningful diagnosis buckets for pelvic floor dysfunction. Tension and weakness are symptoms of how the pelvic floor is adapting to the system around it, right? They are a symptom of the system. We have to find the reasons why the pelvic floor is presenting tight or weak, and we have to treat there. Use my root framework, right? Root cause. So you're going to observe, optimize, and transform. Use this with your patients. Just keep that in mind, right? To kind of keep you out of the temptation of putting them in one of those 2 buckets of tension versus weakness. So I want to encourage you, like, pick a patient this coming week, right? Pick a patient and force yourself to answer, what is the driver of the symptom of tension or weakness? What is the system problem that is contributing to the pelvic floor tension and the pelvic floor weakness, right? And start there, address there, okay? So if you guys found this helpful, it would mean the absolute world to me if you would share this episode, send it to your stories, tag me in it so I know that you're loving it. Send this to a fellow clinician that you work with or, that you're friends with, that you think that this could be helpful. And you guys, if this episode kind of like opened your eyes to some things and you're like, dang, I agree with that. Like, it shouldn't just be tension versus weakness, right? Like, if you want a full framework for how to actually connect like the foot, the ankle, the rib cage, the pelvis, the pelvic floor muscles, and if you want to like stop guessing what is the root cause, right? Like, yes, I hear you, Becky. I'm going to stop putting them in a tension versus weakness bucket, but I need help knowing what is the main driver that you're speaking of? How do I know? How do I find it? Be sure you are on the wait list for the spring round of my No Kegels course. We are launching it on February 23rd. It's opening only to the wait list on that day. And the waitlist, I always hook you guys up with great discounts. So be sure you're on it. The link is in my bio. You can also find it, in my profile on Instagram, whatever. You can always DM me if you're like, where's the waitlist? I need to be on it. So get on that waitlist if you have not taken the course. And if this episode was like eye-opening to you and you're like, yes, I need it. I need the framework. I got you. So I hope you guys have such a great day. Tag me, share it, all the things. Thank you so much for listening, y'all. And let's change the game.